I will answer that tomorrow.
Excellent.
So Ernavan will start, and then. Oh, is there any problem if we record this presentation?
No, go ahead, record it.
Okay, thank you.
All right.
Yeah, we're already on Zoom and YouTube. We're streaming on YouTube as well.
All right. All right, Louis, we are going to start with the presentation, with the introduction, and I'll let you then with your presentation.
Okay.
All right, let's share the screen here. Start with the presentation. All right.
You were showing your presenter view.
Oh, yeah. Sorry about that. It's because, oh, is it that way? There. ¿Se ve bien la pantalla? Can you see the screen?
You can now, yeah.
Okay.
Oh, perfecto, Hernán. Se ve perfecto.
Perfecto. Bien, iniciamos entonces. Bueno, queridos colegas, le damos la bienvenida a todas las y los colegas que se han conectado hasta el momento. Sigue llegando gente, así que les agradecemos, por supuesto, a todos el tiempo. Vamos a dar inicio a esta jornada de la Sociedad Chilena de Kinesiología del Dolor 2020. En donde nuestra primera jornada, ¿cierto?, que inicia el día de hoy, tiene por objetivo comenzar con una serie de charlas, ¿cierto?, presentaciones en vivo, con distintos exponentes valiosos respecto al ámbito que nos convoca a todos, ¿cierto?, lo que es el manejo del dolor, lo cual obviamente va a ser una seguidilla de presentaciones que los podemos ver acá, quienes van a ser nuestros invitados. Hoy día tenemos a Emilio Luis Puentedura, ¿cierto?, que ya está conectado con nosotros y va a ser nuestro exponente de hoy. Para el mes siguiente tenemos como invitado Álvaro Pinteño. En agosto, Bernie Lennox. Mar Flores nos acompaña en septiembre. En octubre tenemos un invitado sorpresa, que ya lo estaremos anunciando prontamente. Y cerraremos este ciclo en el mes de noviembre, ¿cierto?, con Adrian Lowe, que también nos acompañará al igual que hoy. También les queremos, para quienes no se han enterado todavía, avisar de que tenemos ya habilitado nuestro canal de YouTube, ¿cierto?, en donde esta misma presentación y las demás que van a venir es en vivo, paralelo, ¿cierto? En YouTube está también emitiéndose la presentación directamente en inglés, bien, ya que vamos a estar transmitiendo con traducción simultánea, ¿cierto?, en 2 idiomas. Para ello, para quienes quieran escucharlo, bueno, directamente en inglés, ¿cierto?, la opción, por ejemplo, está sumarse al canal de YouTube, en este caso. Y para quienes quieran escucharlo en español, con la traducción simultánea, en su pantalla de Zoom, ¿cierto?, van a poder elegir en la zona inferior, donde está marcando la flecha, ¿cierto?, el icono de interpretación, donde ahí van a poder elegir, ¿cierto?, las opciones de español, como se muestra ahí en la imagen. ¿Ya? Español, bueno, su programa puede estar en inglés o en español, ¿cierto?, pero la opción aparece ahí mismo. Si ustedes eligen el canal español, van a empezar a escuchar la voz de nuestra traductora, ¿cierto?, que nos está acompañando hoy día, que va a ir hablando en paralelo, en simultáneo, en tiempo real con el expositor. Si eventualmente quisieran escucharlo en inglés en Zoom, deben colocar su canal en off o apagado en la misma opción de interpretación. Para quienes nos van a acompañar, ¿cierto?, más tarde, una vez que haya terminado de hablar nuestro expositor, deben cambiar su canal a apagado. Bueno, Y hoy día nos acompaña, como les comentábamos, el doctor Emilio Puentedura, ¿cierto? Emilio Luis Puentedura, quien es profesor, en este caso, a tiempo completo del programa de doctorado de la Universidad de Baylor. También una experiencia clínica, ¿cierto? Muy amplia, licenciado en Ciencias Aplicadas en Fisioterapia, ¿cierto? Y un diplomado en Terapia Manipulativa de la Universidad de La Trobe, en Australia. Básicamente, una vez que haya llegado y se estableció en Estados Unidos, ¿cierto? Desarrolló su doctorado en Kinesiología en el año 2005, y un doctorado y otro doctorado en Kinesiología en Physical Therapy, ¿cierto? En la Universidad de Nova Southeastern en Fort Lauderdale, Florida. Emilio Puentedura ha sido especialista clínico ortopédico, certificado en Estados Unidos y miembro de la Academia Estadounidense de Fisioterapeutas Ortopédicos y Manuales, ya por 30 años a la fecha. 10 años como docente en la Facultad de la Universidad de Nevada, en Las Vegas, y tiene una amplia bagaje de más de 25 años, ¿cierto?, en la enseñanza a estudiantes de fisioterapia y kinesiología en Estados Unidos y en varios países del mundo. De hecho, hace unos años también nos acompañó aquí en Chile en unas jornadas de capacitación. Bien, así que le agradecemos que nos acompañe nuevamente en esta oportunidad. Y por supuesto, también tenemos que reconocer sus más de 60 publicaciones científicas a partir del año 2010 a la fecha. Bueno, el itinerario de hoy, ¿cierto? Esperamos contar una charla de aproximadamente unos 40 minutos. Después de eso hay una franja de 20 minutos de preguntas, las cuales les vamos a agradecer que las vayan haciendo por escrito, ya sea en los comentarios del canal de YouTube, ¿cierto? Para quienes se conecten allá, o a través del chat de Zoom. En este caso, todas las preguntas, por favor, por escrito, y se van a ser transmitidas, ¿cierto?, al expositor para que las vaya respondiendo. Luego de eso, para los que estén interesados, ¿cierto?, en acompañarnos, va a haber una charla cortita, una sesión pequeña directamente de la Sociedad de la SOCHIKIDO, para dar a conocer esta vez los estatutos, ¿cierto?, los lineamientos generales, en este caso de la sociedad, y las formas de participación para los que ya se quieran sumar a esta iniciativa, ¿cierto?, que estamos tratando de darle ya la formalidad necesaria. Así que eso, el presidente de la sociedad, Nelson Adrian, ahí nos va a explicar un par de cosas, ¿cierto?, después de la charla y de la ronda de preguntas. Bueno, queridos colegas, sin más, pasamos entonces a lo que nos interesa, ¿cierto?, que es escuchar a nuestro expositor de hoy, ¿cierto?, a don Emilio Puentedura. Emilio, all yours.
All right. You can hear me well?
Yeah.
Very good. Let me just set up my list of participants, and so I can follow the questions if I see things in chat. There we are. Okay. Thank you very much for the invitation. And I need to remember that I can just keep talking because I'm being translated at the same time, which is quite a good deal. Okay, so I'm going to talk about pain neuroscience education and manual therapy. And the first disclaimer I need to make is that I do publish some books for professionals and patients on manual therapy and also pain science, and I receive an honorarium for those sales. But these aren't being specifically promoted in the presentation. The main intent is just to share some of the research, not to promote the products. I also present for a seminar company, Evidence in Motion. And again, it's not my intention to promote sales of continuing education for healthcare providers, but just to share the research. So moving on. Interesting, those books that I do publish, or have published, on pain neuroscience education and thrust joint manual therapy skills. The objective of today really is to show you how these two can merge together and show you how pain science and manual therapy can work together in a hands-on approach. So let's briefly cover what I'm going to talk about today. First off, we need to understand that pain neuroscience education, or PNE, is really considered the best approach for people who have chronic pain. Most people would understand that. People with chronic pain need to understand that their pain may have little or nothing to do with their tissues. So the reason for their pain may have nothing to do with their discs, their joints, or their muscles. And so therefore, if you use manual therapy in someone who has chronic pain, it seems to run counter to the points that are raised above, that PNE should be for chronic pain, and people need to know that it's not really coming from their tissues. So why are you doing manual therapy to their tissues? And really, that's the crux of what I'm going to talk about today. Let me start by telling you a little bit about my personal history in manual therapy in the early 1980s. And back in those days, the medical model of pain seemed to work fairly well for me in my early years of practice. In a sense, it's probably because in hindsight, a lot of my patients presented with primarily nociceptive pain mechanisms. The belief was that if you had greater pathology, you would have greater symptoms. And then the whole treatment approach was basically to apply an intervention and reverse the pathology. So you perform a manipulation using the force and correct any particular problems. The only trouble was that we started to see a lot of patients that have more pain than pathology. They had symptoms that were far, far higher than what the pathology suggested, or there wasn't very much pathology, and yet they had lots of symptoms. So these pain complaints were primarily not nociceptive dominant, but instead had more centrally sensitized pain states. I'm getting some feedback. Oh, no escuchas la traducción. ¿Lo tengo que hacer en español?
No, Louis, don't worry. We are
Okay.
explaining her how to switch to the Spanish or English.
Very good. Okay, can I continue then? All right. So suddenly we started to see lots of these patients with pain everywhere, and they had probably had more centrally sensitized states. So suddenly our medical model of pain, that symptoms were related to pathology, just didn't work anymore. And now we've got this problem of persistent pain. And here in America, almost 1 in 3 Americans are suffering from some form of persistent or chronic pain. And it's a huge problem. And the US government, of course, is supplying lots of funding to try and correct this particular issue. And they're worried about it. Take, for example, the fact that Americans make up only 5% of the world's population, and yet they consume 80% of the 80% of the global opioid supply and 99% of the global hydrocodone supply. Look at all the other countries, how very little opioid use they have. The global mean is only 6.28, and the US is more than 10 times that amount for morphine consumption in 2012. And in 2020, it's probably worse than that. This is a graph that depicts the number of deaths in North Carolina, just one state in the United States, North Carolina, from 1999 to 2011. And it looks at the associated heroin abuse. So these are deaths because of heroin abuse for that time period. And you can see it's relatively flat, less than 50 people dying each year, a little bit of a spike in 2009 and 2011. And then in blue here, we can see the cocaine use. For some reason, there was a bit of a spike just towards the ends of George W. Bush's presidency, and then it came down during Obama. That's nice. But look at this. This is the prescription opioid pain relievers. Prescription opioid pain relievers. This is, heroin and cocaine, which are illegal drugs, and these are legal medications. And look at the number of deaths, how they've skyrocketed. This stopped at 2011, and it'd be interesting to look at the current data And for 2020, I believe it's well over 1,000 now. It has steadily climbed up to well over 1,000, even though they've done a lot to change things. Why is this so? And I think part of the problem is the way that we've looked at pain is wrong and not correct. A lot of what we've learned we learned in physiotherapy school, kinesiology school, is that the mechanical view of pain, Rene Descartes view of pain, and despite the recent advances in knowledge about the neuroscience of pain, the predominant view of pain still remains outdated, still this outdated view. And many within the health professions are still taught and believe that pain is an input into the brain, that pain occurs or pain originates where a person feels that pain. And again, this is the Rene Descartes view of pain, and it's obviously very wrong. What are some of the things that are wrong with the Rene Descartes view of pain? Well, first off, there's this assumption that there's a direct link between the amount of tissue damage and the level of pain that's experienced. And most patients actually believe this. But it doesn't make sense, because if it was true that there'd be a direct link, then why would a paper cut hurt so much? A paper cut is minimal tissue damage, and yet it hurts quite a lot. Or when you stub your toe and you're walking barefoot in the house and stub your toe, why does that hurt so much? And then very quickly disappear. So this is obviously not correct. Then there's the assumption that all pain is caused by injury, and increased pain means that there's more damage. And again, this is not true, because many people have incredible pain and yet no injury at all. They can recall no particular injury or at all. Then there's pain is either physical or psychological. This is the mental versus psychological pain, or mental versus physical pain. Again, that's not true. You can't really separate it. Pain is pain. And then in chronic pain, tissues are not healing and damage is ongoing. That's not true, because the tissues heal. And over time, tissues do their best and will heal to their best of their ability. Pain that's still ongoing is a pain problem and not a tissue problem. And finally, that nociception and pain are not synonymous. You don't need nociception for pain. You can have pain without nociception, and you can have no pain with nociception. They're not related to each other. There's pain education, and how do we as physical therapists educate our patients about pain? For all these years, we've been stuck with a very Cartesian thinking. And so if we have someone who presents with back pain, what do? We teach them about the anatomy of the back. We talk about the lumbar spine, the vertebra, the ligaments, the muscles, the transversus abdominis, the discs, the nerves, right? We don't educate patients about their pain, and we don't really explain the reason for their pain. A lot of the models that we use in education are very biomedical. So we teach them anatomy, we teach them biomechanics, and we teach them pathoanatomy. And the interesting thing about this is that these prevailing models that focus on the tissues and tissue injuries, the ones that are so orthopedically based and used all the time, they actually make matters worse. Right? Research into the anatomy and biomechanics and pathoanatomy models show that it actually increases fear in patients. And that increase in fear may actually increase the pain as well. Now, around the early 1990s, a new branch of manual therapy emerged from manual therapy, and this was called neurodynamics. Initially, it was called neural tension and mobilization of the nervous system. The book by David Butler came out, and it really provided a brand new tissue for manual therapists to be looking at, besides joints, the facet joints, ligaments, discs, muscles, all those kinds of things. And so neurodynamics became this new approach to look at the other patients in manual therapy that weren't getting better with straight manual therapy. But that didn't seem to capture everyone, and soon Louis Gifford, and again David Butler and Laura Mersley, promoted this new approach of pain science, and pain science took off. All right, pain science took off, and it very soon looked as if there were two very divergent or separate streams of care for two seemingly different patient populations. The patients who had primarily nociceptive pain, treat them with manual therapy. The patients who had primarily nociplastic or central sensitized pain, treat them with pain science. Is it really in the tissues? Manual therapy. Is it more in the brain? Pain science. And it seems like the two couldn't be sort of joined together. You either did one or you did the other. But do they really need to be separated? Why can't they just talk to each other? Why can't you use a pain science approach with manual therapy? Why can't you use manual therapy with the pain science approach? So let's just start off by looking at this. If you were to step off the curb on one of those busy streets in Santiago, Chile, and twist your ankle and sprain your ankle, would it hurt? Now, most of you would say, yes, of course. You've probably rolled your ankle many times and felt that pain. And so you understand, yeah, absolutely it would hurt. But what if at the same time that you twist your ankle, you see this speeding Santiago bus screeching towards you? Would the ankle still hurt? Now, most of you would say, no, not right away, because the bus represents a greater danger to you. If you stop there on the road and fall on the ground and clutch your ankle, that bus is going to run right over you and you're going to have a bigger problem. You'll probably die. So most of you won't feel the ankle pain and you'll run across the street, get out of the way of the bus. And then once the bus is gone, you'll start to feel pain. This lets us understand that pain is a decision by the brain based on perception of threat. We now know that pain is 100% of the time a conscious decision based on the perception of threat. Our wonderful brains will weigh the world and decide what's most important for our survival. And it will correctly decide that feeling pain in the ankle won't be advantageous while there's a bus about to run over and kill you. So you'll hopefully get out of the way of the bus, and then when you're safe from the bus on the sidewalk, that's when you'll start to notice the ankle pain and take action to address the new injury to the ankle. Now, sometimes we can be tricked into thinking that there's a threat. Let's look at this little video, for example. Most people, when I show this at conferences, make an audible sigh or a, they immediately want to cover their eyes because they see this and it looks painful. And some people actually almost feel pain when they see this video, especially because it keeps playing over and over again. But the thing to note about this is that this fighter here doesn't know that he's broken his tibia and fibula until he goes to stand on it. He's kicked that guy, and if we could put a stethoscope on his head, he's probably thinking, just as he's kicked the other boxer, he's thinking, oh, that was a good kick. I'll get a few points from the judges for that. I snuck one in, that hurt him. And then as he's stepping on that right leg, he's falling over, and he's not understanding why he's falling over. And it probably isn't until he's on the ground and he suddenly sees that his foot is next to his hip or knee that he realizes that something's wrong here, and he may or may not feel that pain. Right. It's neurophysiologically as simple as this. A nociceptive or a danger message is going to be sent up to the brain via the spinal cord and the peripheral nervous system. There, the message is received by the brain. The brain needs to make a decision. How dangerous is this really? And if it decides that for whatever reason it's not dangerous, it can send down powerful inhibitory modulation that will effectively shut down the nociceptive drive or the danger messages. I have a classic example that happened to me when I was very young in Australia. I was out hunting with some friends in the woods, and we were hunting at night, doing some night shooting. So we had a big spotlight. We had a big truck that we all were on the truck, and we had rifles, and we were enjoying ourselves, enjoying a few beers as well. And I shot a fox, a red fox. And back in those days, the pelt or the skin of a fox was worth quite a bit of money. So it was really good to have been able to shoot a fox. We stopped the truck. I hopped off the truck, walked out to get the fox. And then as I got close to the fox got up and ran away. Now, we had a rule that we were supposed to follow when we were hunting together, and that is that the guys in the truck don't move the truck, don't move the light, and they certainly don't shoot when someone is off the truck. But this went out the window completely, because as soon as the fox got up and started running, they moved the light, they started moving the truck, and they started shooting at it. And I'm left out there in the dark thinking, they've forgotten that I'm out here in the dark. So it was a little bit scary. I thought, this is dangerous. But then the fox turned around and started coming back towards me, and the light was coming towards me, and the shooting was coming towards me. So then I started to worry a little bit more. So I made myself into a little ball, fell down on the ground, made myself as small as I could, and I heard this shot come really close to me. And I felt something hit me in the back. So I got this message that went from my back muscles, it went straight up through my dorsal root ganglion, into the dorsal horn, straight up to the spinal cord to the brain. And what that message, how my brain interpreted that message, was the shot landed just next to me. I could hear it landing very close to me, but it didn't hit me. It landed close to me. And it must have kicked up a stone, because that was a stone that hit me in the back, just a little stone, right? It didn't hurt much. It was just annoying that I got hit by a stone, and even more annoying because it could have been worse, could have been more dangerous. So I got up very quickly, yelled at the guys and screamed at them that they were stupid, they forgot that I was out there. And they did. And they acknowledged that they'd forgotten that I was out there. And they came over towards me with the light and then looked at my back, and I had actually been shot in the back. So they had to take me to the hospital, and it wasn't until the bullet was pulled out that I actually felt any pain. So this is a situation where my brain made a mistake. It thought it wasn't that dangerous, and it didn't produce any pain. So I had lots of happy chemicals to stop it all. I didn't feel any pain at all. My brain basically thought, this is not a big deal, stop bugging me. So I'm sure I had lots of nociception still streaming up to the brain, but the brain had just quietly turned off all the taps and just said, nah, this is not a big deal, you're okay, no pain. It wasn't until the bullet hit that little tin can that I felt some pain. And then for the next 3 months, as I was recovering from a bullet wound and stitches on my back, that I realized, that hurts. So I had a lot of pain. Now, on the other hand, the brain can decide that something is dangerous and poses a significant threat to survival. And what it can then do is send down powerful excitatory information, excitatory modulation that will effectively ramp up the nociceptive information and produce pain to protect, right? In this case, the brain is more curious and it really wants to know more, okay? So 6 months later, I'm still with these friends, and we get out together. We go hunting one more time, and this time I'm definitely never getting off the truck with these guys. I'm staying on the back of the truck no matter what. We're out hunting just like we were before. Guns, big lights in the middle of the night. It's very dark. And one of my friends shoots a fox. And I'm thinking, your turn to get out there. And he went out and started to get out. But as he went to get out, I told everyone, make sure you put your guns down. Let's not move the truck. Let's not move the light. Let's be safe. And then right behind me, I heard a gun discharge, and I felt something hit my back. So I had this nociceptive input travel right up the nerves from my back into the dorsal horn of the spinal cord, and it went straight out to the brain. And my brain obviously thought about what had happened last time and decided, I'm not going to get it wrong this time. And it produced a massive amount of pain. I thought that I was dying. I thought that I'd been shot really close up, and it was terrible, awful pain. It was just crying with pain. But all the guys had the lights, and they're carrying on. And Louis, you're okay. There's nothing wrong. You're fine. We didn't shoot you. You haven't been shot. What had happened was the guy behind me was putting down his rifle, and as he put down the rifle, it discharged, and the shoulder the rifle butt where you put your shoulder, kicked back and just touched me in the back. I didn't have any bleeding, didn't have any injury, anything like that. But, even though I knew I hadn't been shot and it wasn't dangerous, I had almost a repeat performance of the same pain I had the first time. For several months, I had back pain, leg pain, swelling. It was awful, even though I knew that nothing serious had happened. That I really didn't have a lot of nociception, but I produced a lot of pain. The thing that's really important is that all pain is normal. All pain experiences are really excellent, though unpleasant responses to what your brain judges to be a threatening situation. Even if problems do not exist in your joints, muscles, ligaments, nerves, immune system, or anywhere, it won't hurt if your brain thinks you are not in danger. Right? Even though there may not be any problems, even though there may be some significant problems, if your brain doesn't think you're in danger, it won't hurt. Conversely, if there are no problems whatsoever that exist in your body tissues, your nerves or your immune system, it will hurt if your brain thinks that you are in danger. And it's as simple and as difficult as that. And the really amazing thing is that if you can communicate this to a patient, it can be remarkably freeing to that patient that has chronic pain. Really, the aha moment came when I heard Louis Guilford talking about pain mechanisms back in the late 1990s. He was basically saying, if your patient comes in with low back pain, why are you explaining or teaching to them everything about the back? You should be teaching them about pain. And I was guilty of this because I was always grabbing models of the spine and teaching people about normal spines and abnormal spines. Louis Gifford gave us the mature organism model. I'm sure you've all seen this, and I hope it's changed the way that you see pain like it did for me. It emphasizes what we now know with absolute certainty. Pain is an output. Let's circulate there, right? Pain is an output. It's an output from the nervous system and output from the brain in response to actual or perceived threat, right? The tissues are constantly sending information to the brain, but the tissues are constantly sending innocuous information. If you're sitting down right now, the senses, the nerves, everything in your bottom, in your butt, is sending messages to your brain that alert you to the fact that you are seated. You can feel the pressure there, but your brain's smart enough to ignore it. It's just noise. It just turns down the squelch and decides that's not important to know about. You also have nerves telling you that you are wearing clothes. If you think about it, you can feel your clothes. You can feel the shirt around your neck. You can feel the band around your shoulder. You can feel your underwear if it's a little bit tight. These are all things that you can become aware of if you think about it. But the brain can ignore it because it's not that important. It can switch it off and not listen to it. But if an injury occurs, then it will want to listen to it if it thinks that it's something serious. And the response may be production of pain to make you stop doing something like that, and then some sort of action or some sort of stress regulation. If you sprain your ankle, the action might be to limp for a little while, to go to the doctor to see if there's a fracture, to use crutches for a little while to stay off it, to wear a bandage to compress it. These are all different action programs that occur as you go to protect it. So once again, if pain is produced by the brain, it does so when it's perceived as a threat to survival. Okay? It has to be based on a perception of threat, whether real or not. So that leads us to think that if we can alter threat, we can alter pain. What if that model showed us was that we can treat patients from a bottom-up approach, right, which is manual therapy. We can do manual therapy, motor control, and exercise. That's a bottom-up approach. Or we can use a pain neuroscience top-down approach, right? We're teaching patients, providing psychosocial approaches to get their brain to think differently about what they're feeling, so it doesn't have to be pain. But rather than it be or, perhaps it should be and. All right? It should be and rather than or. And I want to show you why this might be better for most patients that we encounter in clinical practice. I wrote this narrative review with Tim Flynn last year, and we wanted to point out that manual therapy has been shown to have more than just a mechanical effect, because the aim of P&E is to shift the patient's focus from tissues in the low back as the source of their pain to the brain's perception of inputs. Many clinicians were going to be mistaken into thinking that P&E should be hands-off, right? It should be education only. But manual therapy, as well as producing these local mechanical effects, within the P&E context, can be seen as meeting or perhaps enhancing patient expectations and also refreshing or sharpening the body's schema maps within the brain. Let's explore that a little bit more. Right, so can manual therapy sharpen Josh's homunculus? We all know that in our brains we have these body maps, the motor homunculus, the sensory homunculus. There are these humanoid maps of our bodies everywhere, dispersed everywhere throughout the brains, but the ones that we think the most of are the sensory homunculus and the motor homunculus. And the interesting thing about them is how they're not proportional to our body. We have a huge amount of cortical area devoted to our hands and our face, and not so much for our trunk, hips, and lower extremities and feet. All right, and that's because we do a lot more with our hands and with our face. The other thing to realize is that these maps are very plastic and they change a lot. If you're blind, during the week, the fingers that you use to read Braille will be very big. But over a weekend, if you're not doing any reading for 2 days to have a rest over the weekend, those fingers become small. And then they become big again as soon as you start using the fingers to read them the following week. It's actually been studied using brain imaging. Now, this is a very beautiful metaphor to explain the changes that occur within the brain that are associated with chronic pain. And it was put forward by Karen Litzy from New York. So I want to give her some credit for this, okay? You ask your patient to look at the details of this Caravaggio painting, right down to the definition of the fingernails. Look at the fingernails on the boy's hand. This is a boy. And this is what the sensory part of the brain sees when it's firing at full strength, right? And the homunculus is super sharp and focused. This is the image that our brain has of our body. Then ask the patient to look at this picture and compare this Picasso painting where the outline of the body is much more difficult to make out. Everything looks obscured. You really can't make out the exact outline of the body. And this is what happens to your brain when you have a persistent pain situation. The brain can't seem to make out a clear representation of that body part, and it may explain why pain seems to move around a lot. So what about this? How can we address smudging in the brain? Right? If someone has an area, say the back, that isn't as precise as it should be in the sensory homunculus, how do we improve it? Maybe we can improve it with manual therapy, doing some central PAs, unilateral PAs. Maybe we can do the same thing for the neck as well. Right? Evidence does suggest that there's a place for laterality training, teaching people to know and recognize left from right, 2-point discrimination, and motor imagery. But what about skillfully delivered manual therapy from the warm, comforting hands of a physical therapist? Adrian and colleagues from St. Ambrose University conducted a really interesting randomized clinical trial which suggested that manual therapy, a grade 2 PA MOB to the low back, could actually be treating the primary somatosensory cortex. They had 62 patients with chronic low back pain. Their mean age was 60, so they were older people. The mean duration of their back pain was almost a decade. They almost had 10 years of pain. Right, 62 patients, about 10 years of chronic pain. They measured low back pain with a numeric pain rating scale, leg pain with the same numeric pain rating scale, the Oswestry Disability Index, their fear avoidance belief questionnaire, and they also measured forward flexion, and they measured that by distance from fingertips to the floor. Asked the patients to bend forward as far as they felt comfortably bending forward and measured from fingertips to the floor, and then straight leg raise. And they did this before and after a manual therapy intervention, and everyone got the same manual therapy intervention, the central PA, grade 2 mobilization. So basically, this is a grade 2 for about 45 seconds. Okay? Now, The interesting thing about this is that the groups were given two different explanations of what the technique was all about, right? The first was the control group, and they were given a biomedical explanation, a biomechanical explanation of manual therapy. So they were shown a picture of a spine and said, this is what your back looks like. There are 5 vertebrae with spongy discs in between them, right? And little holes for the nerve roots to come out, so supply all your muscles in your leg and the back and everything. And when life is good, each of these joints move just a little bit so that they contribute to the overall motion of the spine. Now, we've detected that you've got one level of the spine there that's not moving as well as all the others. So this technique is going to help that segment move so it contributes better to the overall motion, and that'll make you feel better and move better. That was the biomedical explanation. But then they had an experimental group that were given a neuroplasticity explanation for the technique. They were given this picture and shown, look, in your brain, you have these maps. All of your body parts are actually represented in different parts of the brain. And when life is good, all of these areas are very neatly and acutely and sharply focused. So the brain knows exactly where different parts are. If we were to touch you here, you'd feel it in the arm. Touch you here, and you would feel it in the fingers, okay? And when life is good, everything is super sharp. Now, you've got back pain, so if we were to touch you here around the trunk, it's not as precise. And so we can touch you here, and you feel it in the back. We touch you here, and you feel it in the back. We touch you here, and you feel it in the back. We touch you here, and you feel it in the back, because the brain doesn't know exactly where the back is. So we're going to do this technique to sharpen up the map, to improve the somatosensory cortex map, and that will make you move better and feel better. So different explanations, same treatment technique. Now, it was a quick pre and post intervention, so there was no significant difference between the groups for the outcome measures, all of the outcome measures, except for the straight leg raise. The straight leg raise was actually increased in post-intervention in the experimental group. And that was interesting, out of the 61 subjects, to get a significantly greater straight leg raise following that explanation. And yet it was the same treatment technique. It really brings this idea that, a neurodynamic technique, a straight leg raise, might be perceived as less threatening or less painful if there's a neuroplastic explanation of what the manual therapy technique does. And really, this idea of remapping the brain, it comes from some of the ways that we were taught manual therapy years and years ago. I trained under the Maitland approach, and here's a video of Maitland actually. Oh, it's not going to play. I have to change it to this. There we go. Now, I don't expect the translator to be able to hear what he's saying, but he's basically applying a unilateral PA to this guy's neck, and he's asking him whether, when he pushes in one spot versus this next spot, whether it feels the same, and does one particular spot reproduce his pain. His pain was in the supraspinous fossa, and he said, has that one reproduce his pain?
Should I go higher or lower?
And he's asking, should I go higher or lower? Does it change if I press down or press up? And that's the one that reproduces his pain. And if he pushes harder, what happens?
How does that side compare?
And now he's asking, what happens when I go to the other side? And I press on the same level at the other side. So in a sense, constantly talking to your patient when you're using these unilateral PAs, you really are remapping the brain. The dialogue that we have with our patients with manual therapy can be seen as a way of remapping, sharpening the maps within the brains. When we do manual therapy with our patients, we very rarely just, have our patient lay quietly and shut up, don't talk to me, just let me do what I need to do. We often talk to our patients to get some examples and get some feedback about what they're feeling as you're doing things. We also wrote this paper here in JMMT, and that's been out for a year or two, I think now, where we presented the case for a clinical perspective on P&E approach to manual therapy. And hopefully you've seen this image before. It's from the nervous system and from our textbook that talks about how the nervous system functions as an alarm, right? It's an alarm that's activated in response to an injury or a threat, and how in some cases, after the alarm has been set off, after an injury has occurred, and especially with people with chronic pain, the alarm never really returns back to its normal resting level, its normal pre-injury, pre-threat resting level. It stays extra sensitive, right? And we can view our manual therapy technique really as graded motor imagery, graded exposure in a sense. They're graded mobilizations, right? And we aim to actually touch it, tease it, nudge it, and basically create more space for activities, creating a window of opportunity for our patients to experience movement and exercise without igniting their pain. So we can view our manual therapy techniques as not just loosening stiff joints, but helping to sharpen the map of the back in the brain. Why can't we ask our patients during our mobilization techniques of where we're pushing? You know, am I high or am I low? Am I on the right side or am I on the left-hand side? Which way am I moving? Am I pushing to the left or am I pushing to the right? How heavy am I pushing? Is this light or is this hard? Ask for that feedback as well as doing the technique. There's plenty of evidence to suggest that manual therapy and manipulation have neurophysiological effects. And there's this interesting study by Sam Path and others from New Zealand that they looked at the central nervous system changes following spinal manipulation associated with supraspinal mechanisms that control pain. And in particular, they were looking at the anterior cingulate cortex, the amygdala, the periaqueductal gray area, and the rostroventral medial cortex, rostroventral medulla. I'm going to have a sneeze here in a minute. All right, good. This is the image from their paper, and it suggests that a spinal manipulation or input sets up a cascade of events within the supraspinal centers that results in reduced pain, a downward inhibition, if you like, autonomic activation, and opioid-independent analgesia through endogenous release. This is another study by Tiedemann and others, Laura Tiedemann, and she used EEG, electroencephalography, to compare bottom-up and top-down mediated modulations of pain. Now, they found that the stimulus intensity, or the bottom-up modulated pain-evoked potentials, and the pain-induced alpha and gamma responses, right? And placebo analgesia was where top-down associated with changes of evoked potentials, but not alpha and gamma responses. The key finding really was that pain-related neural responses were differentially sensitive to bottom-up and also top-down modulations. In other words, it was complementary, a top-down. Oh, excuse me. I feel like I'm going to sneeze. Nope. Okay, so it's complementary. It doesn't have to be only bottom-up and only top-down. If they complement each other, it should be both bottom-up and top-down. And this is where we come back to our patient with chronic pain, where we may have determined that tissue injuries or damage is not likely a significant cause for their persistent pain. And we argue that with P&E plus, there's a lot we can do. This is one of the drawings that Adrian and I came up with, this idea that we have 4 cardinal points: pain education, aerobic exercise, goal setting, and sleep hygiene are important, of cardinal points. But then patients can choose what they want for other things to do, right? The research shows that when we do this kind of approach, it's very effective. And note that manual therapy is one of those things. It's one of the options for our patients, and it's not off the table for our patients with chronic pain. And that's where I'll end. Thank you. I want to acknowledge a lot of people that I work with and do a lot of research with. These people here, And a big shout out to my daughter, Dr. Georgina Puentedura. She's an emergency physician here in Las Vegas, working really hard during the COVID-19. So I'll close it now and leave it open for questions.
Thank you very much, Louis, for your presentation. It was great information, up-to-date information. So I really appreciate, in the name of all our society, the SOCHIKIDO, our new martial art. We are really, really excited for your help. Pasamos, Gustavo, si quieres, para algunas preguntas.
Sí, hago una primero. ¿Puedo hacerte en español, Luis?
Yeah, yo lo voy a entender si lo dices en español.
Okay.
Pero a lo mejor lo voy a tener que dar la respuesta en inglés.
Sí, la respuesta en inglés, no hay problema. Puedes dar la respuesta en inglés. ¿Qué características debe tener el usuario para que usted determine que es candidato a la PNE y cuáles para excluirlo?
Oh, that's a great question. This is part of the clinical reasoning process when you first meet your patient. And there's some beautiful work done by Keith Smart and colleagues out of the United Kingdom in England. They published a series of papers on pain mechanisms, and where the physical therapists were capable of identifying predominant pain mechanisms in people who have pain. And they came up with 3 categories of pain mechanisms: nociceptive pain, neurogenic pain, and nociplastic or centrally sensitized pain. And they found that certain characteristics, if pain is proportional to the injury, if a patient can indicate where their pain is, and their pain is only a certain area, only onset with certain movements, eased by other movements, right? This is the classic nociceptive pain, the kind of pain that we all hope we see in clinical practice because it's so easy to treat, right? There's a mechanical link, and it's very easy to reproduce the patient pain, but it's just as easy to relieve the patient's pain. And so there are some certain characteristics, if present, you're 100 times more likely to see that this is a nociceptive dominant pain. The second category, the neurogenic pain, is where the pain follows a certain nerve root pathway. So you see neurological signs like loss of sensation or numbness or tingling, pins and needles in a particular dermatome. There may be some actual weakness in a myotome. There may be a loss of reflex associated with that particular nerve root. And the characteristics of the presentation make you think that it's, a radiculopathy, that kind of a pain. It's more nerve-related pain. And if those characteristics are present, then it's approximately 150 times more likely that it is a neurogenic dominant pain. And the last category, the central sensitization, or what we now call nociplastic pain, this is where pain is disproportionate. Pain is everywhere. Everything hurts. Nothing helps. People have difficulty delineating where their pain is and where their pain is not. They feel like it's everywhere. Sometimes the way a patient fills out a body chart gives you a clue, because if they just mark a small area on the body chart, they know exactly where it hurts. It's probably going to be nociceptive dominant pain. But if they color in the entire body chart and they color outside the body, what they're telling you is they're not really sure where it hurts. It just hurts everywhere. And they're the nociplastic type pain. They have exaggerated pain responses. They exhibit things like allodynia and hyperalgesia. So a normal non-noxious stimulus will be perceived as painful, and something that is noxious and normally painful will be perceived as much more painful than it normally would be. And so they're the nociplastic pain. And when they have these characteristics present, it's 380 something times more likely that you're dealing with nociplastic pain. So I would do that first. Evaluate my patient and try and figure out if this is a noci, which category do they fit into. If it's more nociceptive dominant acute pain, I'll probably use very little P&E and a lot more manual therapy. If it's someone who's more the nociplastic central sensitized pain, then I'll probably use more of the P&E and more of the hands-off type approach until they're ready for a little bit of hands-on approach. And I'll introduce manual therapy much later in the stage. The other thing to think about as well as categorizing their pain response is their acuity. How long have they had the pain? Is it acute, subacute, or chronic? If it's acute, more likely nociceptive, more likely manual therapy. If it's chronic, more likely nociplastic, more likely P&E type approach, right? And then, whether they have any red flags, risk factors for chronicity. So if they've got lots of yellow flags, psychosocial, if they've got high psychosocial risk factors, then definitely move them over towards the P&E or the education type approach. And there are different outcome measures you can use, like the pain catastrophization scale, the PCS, the fear avoidance belief questionnaire, and they will tell you when someone's at risk of being, of developing chronic pain if you don't treat them early.
Excelente.
Did I answer the question?
Sí, muy completa la respuesta.
Okay.
Otra pregunta, Luis. ¿Existe alguna herramienta o material educativo que apoye la terapia para la educación de mis pacientes desde las neurociencias del dolor?
Are there any tools that you can use to teach P&E? Yes,
Sí,
there
esa
are.
es la pregunta.
Yes, there are. I think the best option would be to show you what those tools are. And again, I don't want to make this seem like this is a, like I'm promoting something or selling something. I'll get rid of the background for Las Vegas and show you this. I don't know if this is if it's been translated into Spanish yet, but there's this why you hurt system. The card system. Have you seen this? So these are little stories, and they're things that Adrian has put together to teach patients about pain. It's called the why you hurt system, and it starts off with the sensitive nerves. There's a story about the sensitive nerves. So you have a little card that tells you these are the cards that talk about the sensitive nervous system. And you can use these cards to tell the story to your patient, right? And the story might be, let's say you're walking barefoot in the garage and you step on a nail. Would it hurt? And the patient would go, yeah, absolutely it would hurt. I've done that before. How do you know that you've stepped on a nail? Do you have an eyeball on the sole of your foot? And the answer is that we have, see if I can, 73 kilometers of nerves in our nervous system, in our body. All these nerves go into every single part of our body. And the nerves are constantly sending messages up to the brain, right? So when you step on a nail, right, these nerves are constantly sending these messages to the brain about the status of the tissues. Most of the times the messages are, everything's good here, life is good, everything's fine, I'm okay. But when you step on a nail, right, the message ramps up to the firing level and the alarm is set off. The alarm goes off. And that alarm is just a message to the brain saying danger. And the brain has to decide what's happened. And if it decides it is dangerous, when you do something about this, it'll produce pain. And it'll produce pain so that you won't walk on the foot, that you'll pull the nail out. You'll go to a doctor and put a bandage on it. And then the big question we tell our patients afterwards is, when you take that nail out, can you walk on your foot normally? No. It takes several days for everything to come back down to normal. Over time, this line comes down. comes down to normal over time. But in some people, it doesn't. So that's where you can talk about, central sensitization. And there are stories for everything. There's stories about nerve sensors, about nosy neighbors. Nerve sensor stories is all about ion channels to help explain to patients why they feel more pain when it's cold, or why they feel more pain when they move or do any exercise, because they have different ion channels. Nosy neighbors is to explain spreading pain. It started in my back, and then it went to my hip, and then down my leg. This pain is gradually taking over my entire body, and this is where you can talk about nosy neighbors and how the immune system primes the pain system up. So it's got everything in there, including lions and stress, the brain's pain map, the pain and brain, the Body Inc.'s CEO, which is the brain, the chief executive officer, and the emotions and pain, neurogenic inflammation. And these are basically stories that were developed. We felt they were most appropriate for the American population, just through trial and error, because of the way Adrian was using these stories, and I was using these stories, and other clinicians were using these stories and finding out which ones that were helpful over here in the United States. But we really believe a lot of those stories are very similar throughout the world. People are people and experience similar things. I know that in Australia they have a slightly different approach to it because of David Butler and Lorimer Moseley, and a lot of their stories are a little bit more Australian-centric in a sense, but they still work in much the same way.
Excelente respuesta, Luis. Nosotros todavía no tenemos esas cartas en español por el momento, pero pienso ya pronto estarán en español.
Well, la compañía que lo hace tiene que traducirlo en español.
Exacto. Una última pregunta, ¿te parece?
Oh, yeah. Yep.
¿Sí? ¿Cuáles serían los signos de que la PNE falló en un paciente? En el caso que lo haga, ¿cuáles serían las estrategias o toma de decisiones a seguir por parte del clínico posteriormente a la poca respuesta a la PNE?
This is a very good question. I don't think that education ever fails. So when you use PNE on someone, you might not get the success that you were hoping for, but I don't think it's ever a failure, because educating someone about how things actually work is never really a failure. And we often talk about PNE as being, when we're teaching someone about pain, we're basically planting seeds, right? That we're planting the seeds for them to understand and to learn how things are really going on in their body. We all have failures. When we're trying to talk to someone with chronic pain, they may not be ready to hear the message, and because pain is a behavior, and if someone has chronic pain, we're trying to convince them to change their behavior, change their pain behavior. So it's a bit like smoking, right? When someone smokes, and you tell them, hey, education, you shouldn't be smoking. Smoking is bad for you. And there's all these educational tools to teach people that smoking is bad for them. But it's still something that's very addictive. And when someone is a smoker, they find it very hard to change and actually give up smoking. People have spent a lot of money trying to, to create educational programs to stop smoking, but there are still smokers in the world. Same with weight loss, eating too much, not exercising enough. This is a behavior as well. And it's difficult to change your behavior because it's a habit thing. And all we can do with pain science education is basically present it to our patient and hope that they will accept it, hope that they will take it on and decide that, that it's something they can do and something that they want to do. Sometimes they don't want to do it that particular time that you meet them and that you teach them. And often they misunderstand the message and think that you're telling them it's all in their head, because you're telling them that the pain is coming from the brain. So they're thinking, oh, you think I'm making this up. It's all in my head. That's not what we're saying. I mean, we're very careful about how we teach that to patients. But sometimes they just take it the wrong way and they're not ready to listen to the message, and they go away. And several months later, when they've had more time to think about it, they may come back, and then they're ready to work on it. They're ready to do the work and the activity to make a change. So we've done a lot of research on Prochaska's stages of change to look at that particular. There's a researcher named Prochaska who created his wheel on the stages of change, pre-contemplation to action, maintenance, and so on. And it's the same with pain. If some of the most successful patients I've had that had chronic pain are the ones who they're not pain-free, right? A lot of patients they're not pain-free anymore, but a lot of them still have much the same pain. They often tell me, when I think about it, my back pain is still as bad as it used to be before, you taught me everything about my back. But the difference is I can do everything I need to do, everything I want to do, whereas before I wasn't doing anything. So now I'm walking, I'm running, I'm exercising, I'm doing the things that I want to do. It still hurts, but at least I'm still doing, it's not stopping me from what I want to do. And we call that despite the pain, being able to get on with your life despite the pain. It's unrealistic for people to expect to be pain-free because pain's important. You have to be able to feel it.
Excelente, Luis. Le voy a dar la palabra a Nelson porque te quiere entregar un regalo antes de darte la despedida.
Un regalo virtual, ¿no?
Exacto, un regalo virtual.
No, not a real one. Virtual.
Virtual gift.
Oh, a certificate. Oh, isn't that nice? Ooh, that looks very good.
So, Louis, for your great contribution in research and contribution to the growth of physical therapy around the world, we want to give you the honorary membership of our society. I greatly appreciate your participation in this conference and for making the space to be here. So thank you very much, and I hope we can see each other again soon.
Great, thank you very much. You're not going to give one of these to Adrian, are you? Adrian Lowe.
It depends.
Don't give one to Adrian Lowe. I'll be upset with you if you do.
Only for you.
Recording this, by the way.
Adrian will be jealous.
He will be. Yeah. I'm just kidding. It's good that you're going to have Adrian Lowe talk to you in November. That's good. I might see if I can join in so I can heckle him.
Oh, of course. Yeah. So thank you very much, Louis.
Welcome.
Now we will continue with our webinar.
Do you need me here, or
you're free to go if you want to, or you can stay and listen what I have to say if you want to.
If I can stay and listen, I will. I'll just turn off my video and my microphone, and I'll just listen.
Thank you, Louis.
Thank you very much, Louis.
Goodbye, everyone. Gracias a todos.
Bye. Thank you.
Bien, muchísimas gracias entonces una vez más al profesor Emilio Pontedura. También le agradecemos a ustedes. Ha sido una jornada bien interesante, intensa. Así que agradezco también a mis colegas y amigos de la Sociedad, a Gustavo, Enrique y Hernán, que hemos estado trabajando arduamente en esto. Y no va a ser la primera, como ya vieron, van a haber varias presentaciones de otros invitados. De hecho, en noviembre tenemos al otro coautor de todo lo que es Educación en Dolor, el doctor Adrián Lowe. Bueno, agradecer entonces a las más de 150 personas conectadas a través de Zoom y a través de YouTube. Así que qué bueno que hayan podido estar acá y también ha sido un gran esfuerzo que podamos nosotros haber sacado esto a flote. Dale nomás, Hernán. Bueno, ahora quería estos 5 minutos nomás para poder presentar algunas cosas que nos han estado preguntando muchísimo sobre cómo ser socio de la sociedad, cómo poder acceder a esto y cuáles son los próximos proyectos que vamos a tener. Bueno, en cuanto al directorio, que va a estar vigente hasta el año 2022, según los estatutos del Colegio de Kinesiólogos, bueno, yo, Nelson Adrián, como presidente, Enrique Paiva como vicepresidente, el secretario de Hernán Salinas y el tesorero Gustavo Torres. Ese sería entonces el directorio para este tiempo. Más adelante vamos a mostrar cuál es el correo para que nos puedan escribir. También, como ya saben, estamos en Facebook, en Instagram y también ahora hace poquito en YouTube, donde estamos subiendo algunos de los conversatorios que hemos tenido y también vamos a estar subiendo material de vez en cuando. ¿No? Bien, en cuanto a los objetivos de la SOCHIKIDO, no quiero ahondar tanto porque esto está en los estatutos, pero vamos a mostrar acá los más relevantes. El primero sería poder reunir a los kinesiólogos de Chile para, digamos, poder unificar lo que va a ser el interés académico y clínico por el manejo del dolor en cualquier tipo de rango etario y cualquier etiología, ¿ya? Sobre todo para poder unificar criterios e intervención kinésica. Recordemos que el dolor va a ser un área transversal a todo, no solamente músculo esquelético, sino que también en geriatría, también en pacientes con cáncer, por ejemplo, o en deporte, en todo lo que implique que exista dolor, va a ser tremendamente importante el manejo que nosotros podamos dar. De hecho, hace poco salieron algunos documentos que hablan de la necesidad digamos, alta del hospital para pacientes que han estado hospitalizados por COVID, el manejo también del dolor, con lo que decía recién el doctor Luis Puentedura. Como otro objetivo tenemos construir y gestionar relaciones con el medio científico profesional, ojalá a nivel nacional e internacional, para poder ir enriqueciendo nuestro rol y además aportar a la kinesiología, sobre todo con el trabajo multi e interdisciplinario. Súper relevante porque el dolor, al ser multifactorial, necesitamos también actuar con otros profesionales que van a trabajar a la par con nosotros, con terapeutas ocupacionales, con psicólogos, médicos, etc. ¿Ya? Otro punto, entonces, promover la creación de la especialidad de kinesiología en dolor, ojalá con estándares internacionales y además bajo un proceso de examinación. Actualmente la DENACE entrega y reconoce ciertas especialidades de la kinesiología, sin embargo, nosotros dentro de lo que tenemos planteado es que ojalá se pase por algún tipo de proceso de examinación en donde podamos entregar entonces junto con el colegio la especialidad de kinesiología en dolor. Y bueno, y por último, también otro objetivo importante va a ser organizar y realizar congresos, conferencias, seminarios, cursos, reuniones o como ahora este webinar que tenemos para promover el progreso del crecimiento de la kinesiología del dolor. Estos serían los objetivos más, yo creo, relevantes. Y el último, perdón, representar a la kinesiología chilena en el ámbito del manejo del dolor, ojalá ante organismos nacionales e internacionales. Vale decir, cuando se le consulta al colegio de kinesiólogo por el tema del dolor, el colegio lo va a derivar hacia nosotros y podamos dar nosotros una mirada experta frente a lo que puede hacer el kinesiólogo en el ámbito del dolor. Bueno, y para cerrar, ya lo que han estado preguntando muchas personas, ¿cuáles son los requisitos para ser socio? Acá están. Primero, ser kinesiólogo otorgado por una universidad reconocida en Chile. Si hay extranjeros viviendo en Chile, tienen que tener el título equivalente al de kinesiólogo, ¿ya? Así que hay colegas de Venezuela, Colombia, Ecuador que viven en Chile que han consultado y pueden ser obviamente miembros. Además, tienen que mandar una solicitud de ingreso dirigida a mí como presidente, tienen que adjuntar un currículum, una copia del certificado de título y copia de convalidación en el caso de los extranjeros. Y además, recomendación de 2 socios habilitados, ¿ya? Esto es también para tratar de generar algún tipo de filtro, pero en realidad para poder cumplir con los estándares internacionales en cuanto a lo que es la kinesiología del dolor. También un requisito muy importante es que ojalá la persona que quiera ser socio se desempeñe profesionalmente en el ámbito del dolor, ¿ya? Y ojalá que sea demostrable. Y una vez más, en cualquiera de las áreas, músculo esquelético, en el deporte, en geriatría, oncología, etc. Todas las áreas donde se trabaje directamente con dolor. También tener formación demostrable en el ámbito del dolor, ya sea con cursos, con algún tipo de postítulo habilitante, lo que sirva para demostrar que existe algún tipo de formación específica en este ámbito, que como ya hemos visto es una área de especialidad. Y bueno, por todo lo que estamos viviendo a nivel mundial por la pandemia y también como una ayuda para los colegas, el valor para ser socio durante el periodo 2020 hasta próximo año 2021, todo este año va a ser de 10.000 pesos la adherencia como socio. Y para los que estén interesados, entonces pueden enviar su correo a sochikido.chile@gmail.com, en donde ahí ojalá que manden todos estos datos que están acá y también solicitar más o menos los datos para poder hacer el depósito, y nosotros vamos a enviar de vuelta la carta de aceptación, ahí habilitando, ¿cierto? Y va a ser socio de la Sociedad de Kinesiología del Dolor. La idea es que los socios puedan tener acceso a todas estas reuniones, a algún contenido exclusivo también. Así que, bueno, una vez más, muchísimas gracias a todos por estar acá y espero que nos estemos viendo pronto. Recuerden que en el Instagram estamos haciendo una vez a la semana actividades de conversatorios, y además también estamos haciendo estas jornadas, estos webinars, y próximamente se viene un colega desde España con un tema muy interesante para el próximo mes, así que estén todos atentos. Nada más que agregar, no sé si Gustavo, Hernán o Enrique quieren decir algo más.
Agradecerles a todo el mundo nuevamente por el tiempo. Esperamos que obviamente nos sigan acompañando en el resto de las jornadas, que se vienen muy entretenidas. Y nada, pues chicos, a cuidarse todos también.
Dale las gracias por estar aquí hoy conectados en YouTube y en Zoom, y espero que nos puedan seguir acompañando en todas las actividades que tenemos de aquí por delante. Así que gracias a todos por estar hoy día presentes y por acompañarnos hoy día.
No, y también gracias por los 1000 ya seguidores en Instagram, así que nada, pues ojalá nos puedan seguir apoyando, se agradece la confianza.
Así sea. Así que muy buenas noches y nos estamos viendo pronto.